Hello, this is Austin Worth, and this is the second immunology lecture in the MRC PCH Part 1 lecture series. This lecture is titled Immunodeficiency and Autoimmunity. And the aims for today's lecture are to learn a strategy for interpreting data to determine whether or not a child is immunodeficient. To recognise the different patterns of clinical presentation different types of immunodeficiency can take. Also to get an overview of the management and some of the pathophysiology associated with the main primary immunodeficiency syndromes. And finally, we'd like to have a brief introduction to some of the immunology behind some autoimmune diseases. So today we'll start with a question. In an 18-year-old, recurrent and or severe infections with which of the following organisms would make you suspect immunodeficiency associated with hypogammaglobulinemia? Haemophilus influenzae, Streptococcus pyogenes, herpes simplex virus, Candida species, and Pneumocystis jirovecii. And the answer is Haemophilus influenzae. So in this case, we've got a 18-year-old boy, and the question we're asked is whether or not he's presenting, his clinical condition is associated with hypogammaglobulinemia. So we're not interested in viral causes such as herpes simplex. We're not interested in fungal causes, Candida or Pneumocystis, because they're going to be associated with T-cell defects. And if we're looking at strep pyogenes and Haemophilus, it's capsulated organisms that children with hypogammaglobulinemia find it particularly difficult to respond to. So moving on from this, this next slide gives an overview and a bit of a simplification of the organisms that are associated with certain types of immunodeficiency. At the top of the list is neutropenia, and in this setting, that's kind of more referring to acquired immunodeficiency, so neutropenia secondary to chemotherapy. And what we worry about in those patients are gram-negative organisms and fungus. The T-cell immunodeficiencies, we're really worried about viral infections, particularly herpes viruses, opportunistic infections, so fungal infections, Cryptosporidium, Candida, Pneumocystis jirovecii, and also intracellular organisms. Antibody deficiency, as we mentioned in the question before, capsulated organisms, Haemophilus influenzae B, pneumococcus. Also, they have some rather unusual gaps some rather unusual organisms that illustrate gaps in the immunity left behind by a lack of IgG. Enterovirus infection, they're particularly susceptible to Giardia and Cryptosporidium. Complement deficiencies are associated with encapsulated organisms, but particularly Meningococcus. And phagocyte deficiency, so subtly different from neutropenia, but very much similar sets of organisms. So these patients are susceptible to gram-negative infections and to fungal infections, but also they seem to be particularly susceptible to staphylococcal and streptococcal infections and salmonella. And then asplenic patients have problems dealing with capsulated organisms. So the vast majority of this talk is going to be dealing about primary immunodeficiency. However, the number of children with primary immunodeficiency pales into insignificance compared to the number with acquired immunodeficiency. And the most common cause of this is related to chemotherapy. And many patients are actually, although in terms of managing oncology and hematology patients, people get very concerned about neutropenia. Often these patients are actually profoundly lymphopenic, particularly if they've had very long courses of chemotherapy. And it's quite important when you're assessing these children to take into consideration the duration and the severity of the chemotherapy that they've had and just how myelosuppressing it is. many of these patients remain immunosuppressed for a long time afterwards. And a good example of this would be bone marrow transplant, where children still are quite markedly immunosuppressed a year following the transplant. Other children are those on immunosuppressive drugs, and that's the kind of usual drugs that we think of, so prednisolone, cyclosporin, azathioprine, methotrexate and cyclophosphamide, a lot of children with autoimmune diseases and rheumatological conditions. But we also sometimes forget about children who are taking monoclonal antibodies, who maybe get one infusion a month or one infusion a week, such as infliximab and rituximab. These children are also profoundly immunosuppressed. Then there's a whole series of children who have immunoglobulin loss syndromes, protein-losing enteropathies, and Burns patients are good primary examples. And also children with lymphangiectasia, who usually have very leaky guts, or if the lymphangiectasia is in the chest, leaking into the chest, but also lose lymphocytes from that as well, so they can also be profoundly lymphopenic as well as suffering from a hypogammaglobulinemia. Children post-splenectomy, as we summarised in the previous slide, are immunodeficient, and then patients with HIV and malnutrition worldwide are the most important causes of acquired immunodeficiency. Okay, so we'll take another question. Which of the following are true regarding T cells? A, they make up 60 to 80% of the total white cell count. B, they are more frequent than B cells. C, they mature in the thymus. D, they are associated with memory responses. And E, defects can occur in DeGeorge syndrome. So all of these are true except for the first one. 60 to 80% of the total white cell count. Well, it's very varied between the split between lymphocytes and neutrophils, but usually there are more neutrophils than lymphocytes. And T cells only make up about 2/3 of the lymphocytes anyway. So 60 to 80% of the total lymphocyte count would not be terribly accurate. T cells are more frequent than B cells. They do mature in the thymus. They do produce memory responses, and T cell defects do occur in DeGeorge syndrome. So when we want to assess a child to see whether or not we think they've got an underlying immunodeficiency, I'd like to propose making that assessment in a quite specific order. So the first thing and the most important thing is to really take note of the clinical history. And particularly in some of the questions you might get asked, it's quite easy to get blinded by all the investigations lower down in the question, whereas almost certainly there will be a major clue in the clinical history that's being written at the top end of the question. From the history, you need to work out what type of infections this child is having, and are they any more than is normal. The next thing to look at is the full blood count, and I'm particularly interested in the absolute neutrophil count and the absolute lymphocyte count. And particularly in babies, lymphocyte counts are much higher than they are in adults, and any lymphocyte count of less than 2 in a child under the age of 1 needs to be treated with some suspicion. The next things to look at are immunoglobulins, and I'm interested in G, A and M, and then less interested in IgE. The fourth thing to look at will be lymphocyte subsets, and finally the last things, although probably most importantly actually, are tests of immune function. Now the first of these are T-cell proliferation assays, an example of which is a phytohematoglutinin stimulation, or a PHA test. And what happens in this test is that T cells are separated out, or the whole of the lymphocytes are separated, and they're stimulated with PHA, which is a non-specific T cell stimulant that induces T cells to proliferate. And after culture with this for a week, then the rate of proliferation is measured by incorporation of a radioisotope. And this allows an assessment of how activated the T cells are getting. And where you have a T cell problem, a T cell immunodeficiency, then the T cells are not going to be able to be activated properly and are therefore not going to proliferate. The second test of immune function are vaccine responses. So if the child has been vaccinated, we just want to know whether or not they've mounted an antibody response to that vaccination. So what can we gain from looking at the immunoglobulin levels? Well, by looking at IgM, we can tell whether or not the patient is able to make any immunoglobulin. The IgM is the primary antibody response, so it's the first antibody that will be produced in response to a pathogen or a foreign antigen. IgM has the advantage that it's not clouded by placental transfer in a baby, and it can't be absorbed through the neonatal gut. It's very unlikely it's come from anywhere else because it's a large pentameric complex, and it can only have come from the individual. So if IgM is undetectable, that suggests something is seriously wrong, and for some reason the baby is not able to, or the child is not able to initiate the production of immunoglobulin. IgG is also very important because this is a measure of whether or not the patient is able to class switch from IgM to IgG. IgG is the most important immunoglobulin in terms of providing protection for the patient, and therefore it's functionally the most important one to assess. However, there are some catches with IgG that we need to be aware of if we're trying to interpret and trying to determine what's going on. Up until 6 months, even longer, a baby will still have IgG that's derived from their mother that was gained through placental transfer. Also, there are conditions that IgG can be lost from the blood, such as where there's very high gastrointestinal losses or skin losses for one reason or another. And we've already talked about lymphangiectasia in association with this. IgA is an important immunoglobulin that gives us a lot of information. Just like IgG, it is a measure of class switching, but it also tells us very specific details about what sort of protection is being offered to the mucosal surfaces. And mucosal surfaces, of course, refer to the respiratory tract and the gastrointestinal tract, two of the most susceptible places for infection and disease in these sorts of patients. There is a bit of a catch with IgA as well, because of IgA deficiency is very prevalent in the population, and it's unclear what the significance of that is. If you have a very low or absent IgA, it's difficult to know how to interpret that. IgE levels are much lower than all the other immunoglobulins in the circulating blood. However, they can be markedly raised in atopy. They can be very markedly raised in an immunodeficiency called hyper-IgE syndrome, usually to an extent where it's over 10,000. So if there is concerns about hyper-IgE, and the sort of concerns that you would have with this condition are facial dysmorphism, retained milk teeth, pulmonary abscesses, susceptibility to boils and soft tissue infections, joint laxity. If you had a clinical picture that fitted that, then sending off an IgE is very useful, because if it does come back very high, that's quite supportive of that diagnosis. And finally, as we've discussed before, the functional test of monitoring vaccine responses is very useful. And the first-line vaccine response that's usually used is assessment of the anti-tetanus antibody response. So moving on from immunoglobulins to lymphocyte subsets. So the most important thing to look at is the absolute lymphocyte count, which in young children should be above 2 for the first year of life. And if it's less, that has to be repeated. And you have to know that the lymphocyte counts can get up. When lymphocyte subsets are done, lymphocytes are separated using fluorescence-activated cell sorting or flow cytometry, and the T-cell windows are separated based on their pattern in the flow cytometer. Then various CD molecules are labelled using monoclonal antibodies, which allows the number of each different type of cell to be identified. So the T-cell marker usually used is CD3, CD4 and CD8 are used to determine T helper and cytotoxic cells. For B cells, either CD19 or CD20 is used. And for natural killer cells, CD16 or CD56. On some occasions, it's desirable to look at monocytes, and if a monocyte marker is required, then CD14 is usually used. So we've already mentioned that there's usually a bit fewer lymphocytes than there are neutrophils, and there's usually more T cells than there are B cells. Usually approximately 2-to-1 ratio, but that's highly varied. Usually the NK cells will be less than 10%. The CD4 to CD8 ratio should be approximately 2-to-1. Interpretation of lymphocyte subsets requires a lot of experience. If you are going to get a question on lymphocyte subsets in the exam, it will be really barn door. So the T cells will be absent, or the B cells will be absent, or they will be extremely low. So if you're looking at this, don't be concerned about small numbers, and particularly as reference ranges are very, very difficult in young children, you're going to get something that's very, very obvious. It is also worth just thinking about how immunosuppressed some of the children are if you have a low lymphocyte count. And probably the best comparison to that is to compare it to the WHO guidelines for HIV infection, at which in a child under 5, a severely immunosuppressed child has a CD4 count, a percentage that's less than 15% of the total lymphocyte count, and an absolute CD4 count of under 500. Other markers that you may come across but are not very important, just kind of the icing on the cake. CD25 is a marker of T-cell memory, and that is used to look at the differentiation between naive cells and memory cells. MHC class 2, specifically HLA-DR, is an indicator of activation. And CD18 is a marker of an integrin, which is used to assess whether or not a child has a condition called leukocyte adhesion defect, which is a neutrophil disorder where the neutrophils are unable to home to sites of inflammation. So these children have a very high white cell count in the periphery, but are unable to mount normal neutrophil responses. So, question 3. Which of the following are true regarding deranged cellular immunity? A. It often presents with severe viral infections. B. It can be associated with a raised IgM. C. It is associated with gram-positive severe infections. D. It is associated with prematurity. E. It occurs in agamma-globulinemia. Okay, the answers are A and B. So, from everything we've been saying, we know that deranged cellular immunity is associated with severe viral infections. You're not going to get deranged cellular immunity, i.e. T-cell immunity, in agamma-globulinemia. That's an isolated B-cell defect. Prematurity may mean that there are smaller numbers of T cells, but there will be nothing wrong with the T cells, provided there's nothing wrong with the immune system. Deranged cellular immunity is much more likely to run into problems with gram-negative organisms, with fungal infections, with viral infections, rather than gram-positive organisms. Then B is true, which is kind of quite tricky, maybe not what you would be expecting. But there is a condition called hyper-IgM syndrome, otherwise known as CD40 ligand deficiency. And this results, this CD40 and CD40 ligand are real critical co-signaling molecules that are essential for a B cell to class switch from producing IgM to IgG. So as a result, if the children are unable to class switch, they accumulate IgM. And their IgM is generally a T-independent IgM response. So they aren't able to respond to T-dependent antigens. And now this condition, although it has a problem with humoral immunity, it also has a problem with its T cells, because the CD40 ligand is actually a T cell activating molecule, and therefore it has problems with other aspects of T cell signaling. As a result, these children do have a cellular immunity problem and are particularly susceptible to Pneumocystis jirovecii, also to Cryptosporidium, as well as to capsulated organisms. So here's a list of the most common T-cell disorders. SCID is severe combined immunodeficiency. SCID is severe combined immunodeficiency, which means that children are unable to produce functional T cells. And without functional T cells, the whole of their adaptive immunity falls apart. They're unable to generate reasonable antibody responses. B cells are not able to mature and proliferate in response to antigen, and T cells are completely useless. So these children are really profoundly immunodeficient. There are then a whole series of other T cell disorders which have slightly more variable deficiency. Wiskott-Aldrich syndrome, we will talk a bit about later on, has a component of a T cell defect that's really quite varied. We've just talked about CD40 ligand deficiency, or hyper-IgM syndrome. MHC class II deficiency, you can imagine the importance of MHC class II in that it's critical to allow the activation of T cells, and therefore it's not surprising that these children have a clinical phenotype very similar to SCID. DeGeorge syndrome, we will talk about later on, but many children with DeGeorge have, or most children with DeGeorge, have some degree of T cell disorder. And then there's a condition called X-linked lymphoproliferative disorder, or Duncan syndrome, or XLP. Now this is highly varied in how it presents and the degree of immunodeficiency it has. But it frequently does have some degree of T cell abnormality. These children actually run into problems because they're unable to respond appropriately to Epstein-Barr virus, and when they do meet Epstein-Barr virus, they progress very rapidly to hemophagocytosis. Okay, can I just start that sentence again? And when they do run into Epstein-Barr, they progress very rapidly to hemophagocytic lymphohistiocytosis. Okay, so the classical presentation of SCID is a scrawny baby who's obviously finding it difficult to put on weight, usually presenting any time up to the age of 6 months of age. They may or may not have had severe recurrent bacterial infections. They're likely to have had quite bad oral and perineal thrush that frequently does not clear up with first-line treatment. Many of these children have chronic diarrhoea and, as a result, often have electrolyte imbalance. Sometimes these children present onto intensive care units with respiratory failure following pneumocystis jirovecii pneumonia. Alternatively, sometimes these children decompensate with other viral infections, adenovirus, parainfluenza viruses, influenza viruses, or RSV, all of which are very, very difficult for a child with SCID to cope with, and they frequently require intensive care. The other presentation that is quite common is they often have cutaneous lesions, often rashes. And on a chest X-ray, you can sometimes pick up that they have an absent or a very small thymic shadow. SCID is not a single disease. It's a common clinical syndrome with multiple genetic causes. And clues to the genetic cause can be determined by looking at exactly which cells are present and which are missing. So the most severe form of SCID would be no T cells, no B cells, and no NK cells. And there are a number of conditions that can do this, but the most common form is a condition called ADA, or adenosine deaminase deficiency SCID. Interestingly, this is actually a metabolic disorder, which is an inability to remove toxic nucleotide adenosine byproducts, which results in lymphocyte toxicity. But it's also associated with toxicity in a number of other organs, particularly the cochlea and the brain. Many of these children have problems with deafness and developmental delay. In other conditions, the defect is specific to T cells or just T and NK cells. And the most common form of SCID in Europe is common gamma chain SCID, which has B cells are present, T cells are absent, and NK cells are absent. And that's because there's a defect with the signaling pathway downstream from the T cell receptor, so that the T cells are never able to become activated, and the part of that signaling cascade that is critically involved is shared between T cells and NK cells, but not B cells. Of course, the B cells that are present in this are completely useless because they're useless without T cell help, and they do not have any T cells. Okay, so treatment of SCID. Well, initially, supportive care is critical, and that means prophylactic antimicrobials, cotrimoxazole as prophylaxis against PCP, or pneumocystis jirovecii. They should receive intravenous immunoglobulin to boost their humoral immunity. They should receive antifungals as prophylaxis against Candida or Aspergillus infection. And very often, critically, they need extensive nutritional input or support, often with nasogastric feeding. The definitive gold standard treatment is bone marrow transplant. And bone marrow transplant suggests that it needs conditioning to make room in the bone marrow for the donor bone marrow, and as a result, they will have to give chemotherapy. But because children with SCID actually have no immune system, they would not be able to reject an infusion of T cells and, in fact, stem cells from another donor. So in some selected cases, particularly if the child is very well or they're picked up at a very early stage, they can actually just receive an infusion of stem cells from a matched donor. With one of the conditions mentioned, adenosine deaminase deficiency, there is a replacement enzyme that can be given as regular injections called PEG-ADA, and this is able to hold the children until a time when they've actually found a good match for bone marrow transplant, or that they've grown stronger and therefore a better candidate. And finally, gene therapy has been performed on children with SCID, and of course it is a perfect model for that because again they are unable to reject a new transgene that's introduced, and the system that has been used has used a modified retroviral system to put the common gamma chain and ADA genes into the stem cells before they're infused into the patient's own stem cells before they're infused back into the patient. So we'll move on to a new question. A patient presents with hypocalcemic tetany. He has abnormal ears, hypertelorism, and an absent thymus. What is the most likely diagnosis? A. DeGeorge syndrome. B. Wiskott-Aldrich syndrome. C. Gaucher's disease. D. Tay-Sachs disease. E. Ataxia-telangiectasia. And the answer is DeGeorge syndrome. Wiskott-Aldrich syndrome we've already briefly mentioned, and we'll be discussing a little bit about ataxia-telangiectasia later on. Gaucher's disease and Tay-Sachs are both storage disorders. So, DeGeorge syndrome. It's important to consider DeGeorge from the point of view of part 1 because it fits into so many different subspecialities, and therefore it's much more likely to come up than maybe some of the other topics that we're covering today. So DeGeorge is associated with a deletion of on chromosome 22 at the Q11 locus. But it is worth bearing in mind you don't have to have that deletion to have a clinical diagnosis of DeGeorge syndrome. They have multiple cardiological problems as listed down here, and the vast majority of these children do have abnormalities of their heart. They also have marked facial dysmorphism with hypertelorism and short palpable fissures. They generally have quite a distinctive small shaped mouth with a short fulcrum, and often with a small jaw posteriorly placed. The ears are always described as being posteriorly rotated and low set. Being an immunology lecture, I'm more interested in the immunology, which is sometimes can be confusing. So 80% of children with DeGeorge syndrome have some degree of immunodeficiency. A minority, only about 1%, are completely athymic and therefore have a profound immunodeficiency in keeping with a child with SCID. More common is just low T-cell numbers with normal B-cell numbers. And this improves over the first year of life, but doesn't always completely get back to normal. They frequently have a slightly impaired T-cell proliferative response to PHA, and there's a variable degree of abnormality in their specific antibody responses. And that can be despite having normal absolute immunoglobulin levels, illustrating the importance of checking specific vaccine responses in addition to the absolute numbers. And additionally, they have neonatal hypocalcemia, which usually persists for greater than 14 days post-delivery, and is associated, is present despite the fact of a low parathormone level. In the children with a complete, so-called complete DeGeorge, who are actually athymic, bone marrow transplant has not been terribly successful because